Welcome to Health Focus. I'm your host, Dr. Scott. Today we're addressing the story of the year for 2019, and it happens to be the opioid epidemic. According to the Centers for Disease Control, Center for Statistics regarding health issues, nearly 50,000 Americans died in recent years on an annual basis due to opioid epidemic-related problems and specifically drug overdoses. You know, if you put that in context, that's a number that's similar to the number of people that we lost in the entire Vietnam War. And going back 20 years ago, that number was only about a fifth as high. So it's a real problem. And we're trying to shed some light on it here because it's a condition and a problem that has really focused the attention of the entire nation for the past year. And I'm very pleased to introduce our guest, Dr. Dennis Hawley. Dennis has been a friend of mine for a number of years. Dr. Hawley, it's a pleasure to have you here.
Pleasure to be here.
And of course, the issue of the opioid epidemic is something that you and I grappled with when we became acquainted. We were both working as physicians in the Department of Corrections. And subsequently, I think we both worked in the Department of Mental Health, which became the Department of State Hospitals. So we've worked in institutional settings, you and I, and yet we've both moved on to other practice environments. But in your case, your medical history as a doctor has been very interesting. You actually began as a researcher, I believe, at UCSF.
That's right. I had a PhD in molecular biology before I went to medical school. And so when I finished my residency training in medicine at the University of California in San Francisco, they offered me a faculty position to stay on and do research in diabetes. Diabetes is sort of related to treatment of opiates because both insulin and opiates are governed by receptors in cell surfaces, and you can explain many of the properties of both diabetes and the pharmacologic action of opiates by how they bind to receptors and how fast they exchange off receptors and how the receptors internalize and so on. So it isn't as big a shift as you might think. I started working for a local methadone clinic while I was still at the university doing diabetes research, and I became kind of familiar with the literature on opiates because it was necessary to do that to do methadone treatment.
And if I'm not mistaken, you worked at the Haight-Ashbury Clinic, right?
I did. I was the Haight-Ashbury Clinic's physicians are for the most part volunteers. I volunteered there to supervise nurse practitioners. That's like required by the nurse practice law, or it was back in the 1990s. Haight-Ashbury Clinic does primarily non-pharmacologic management of drug addiction problems using group therapy and acupuncture and non-chemical treatment modalities. So considerable difference between that and methadone.
Do you think that I was addressing the opioid epidemic as being really as big of a problem as it should be viewed as, or do you think I was viewing that as being too much of a problem? My feeling is that it is, in fact, the story of the year for 2019. It's a major public health issue, and it's an issue that it's really galvanized the public in terms of their concern over it.
It is, but it's also kind of interesting to note that, like, in 2017, the story of the year was probably the methamphetamine epidemic. So we're having a lot of problems with substance abuse because there's an overlap between the two kinds of problems, and between methamphetamine and opiates, a massive percentage of the public health problems, even things like child custody, interventions to take children out of unsuitable homes, structure fires, all of these things relate to problems with substance abuse. In California, these things are kind of compartmentalized. The primary problems with opiates are in the northeast part of the United States, especially in the Appalachians, whereas California is probably in the brunt of the methamphetamine problem with drugs that come from Mexico. But both of these problems have to be treated by doctors at some point in time. In fact, the entry point for treatment for a lot of people with dependence of any kind is the county jail system. There's so little treatment available that's affordable to people who need help that they end up having to commit crimes to supply their drug habit, and then they become incarcerated. And so the first thing that happens when you come to jail is you go into drug withdrawal, and it becomes an urgent sort of health problem.
Right. I think it's helpful also to differentiate between different kinds of substance use problems. So we're focusing on opioids. You mentioned methamphetamines. Methamphetamines are an illicit drug that can cause a lot of problems, but they would not be under the rubric of opioids, right?
Absolutely not.
So,
right.
And among opioids, we also have the distinction between prescription opioids, which would be opioids that doctors write prescriptions for, like Tylenol number 3 or Tylenol with hydrocodone or what have you, and also the street drugs. So a street drug version would be, for example, heroin, or legally obtained fentanyl that may come in on the black market from China, for example.
Right, and a lot of prescriptions are diverted, so there's also street supplies of things like OxyContin and Vicodin that people get prescriptions from multiple doctors and then they resell their medications. So even for legally prescribable drugs, a patient may not be taking drugs that were legally prescribed for him.
Right. So there's diversion of medication. But let's talk about people who receive prescriptions from doctors. I believe that the statistics suggest that about 6% of people who have an acute traumatic injury, like a broken ankle or a sprained ankle, end up being on opioid medication after the acute event. The prescription is written and it gets refilled and they just continue on with this. I think that that's a problem which we're beginning to recognize in the field of medicine, but I think that the pendulum really swung a little too far towards overprescribing, and that's in part how we got into this situation. What do you think about that?
Yeah, there's a lot of interest right now in research in when does an acute... Normally, we've all had injuries. We sprain our ankle in high school playing basketball. It hurts for a week. It gets gradually better. In a couple of weeks, you forgot all about having an injury.
Right.
But apparently, some small percentage of the time, patients never seem to recover from the original injury, or they believe it gets worse over time. So they hurt their knee, and then each time they come to the doctor's office, they report having more pain in their knee than they had on the previous visit. Why that occurs is really not very clear. There may be even psychological components to your perception of pain at a certain point in time. But if for those patients who continue to experience pain from an injury that appears to have healed, the swelling has gone down and the bruising has gone away, and the person still complains of symptoms, it becomes difficult to know exactly what to do about that, because now you're prescribing medicines for a problem that you don't really see anymore. And so it's like the patient is now sort of self-prescribing. He tells you how much pain he has, and you aim a therapy at, you're treating only the pain, not the injury. That's where they get into trouble, where somebody becomes dependent on opiates.
I think also we have to look at prescription habits of doctors within the context of society at large. And I know that about 20 years ago, there was really a large patient rights movement that advocated for more aggressive treatment of pain. There were some high-profile lawsuits of physicians who were thought to have undertreated pain, particularly associated with end-of-life pain, for example, with cancer. And in the wake of that, there was a political movement to really view pain as being the fifth vital sign, which of course doesn't really make sense, because vital signs are things like blood pressure and pulse that can be measured. Pain is something that's more subjectively reported. But in the wake of that, all physicians in the state of California had to undertake mandatory training in pain management. And my own opinion is that the pendulum swung towards physicians aggressively treating pain with more and more in the way of opioid prescriptions. And I think now the pendulum is beginning to swing back as we get pushback from the Surgeon General issuing directives saying that we should be more careful about this, as this issue has been covered more by the media, and as we've been moved by the tragedies that we've seen from overdoses. What do you think of that historical analysis?
I think it's like spot on. It's interesting that NIDA, that's the National Institute on Drug Abuse, recently came after a big study about why opiate prescribing had been going up and up, said the number one reason was the use of pain scales in hospitals and emergency rooms. A pain scale is where you simply ask the patient on a scale of 1 to 10, how much does it hurt? And I don't think patients, they want, if 10 were like being disemboweled, by a monster, and 1 was a pain that was so small you could barely tell, you would not normally be walking around saying you have a 10 pain. But that seems to be a very common response. It's as though the patients think, if it hurts me, it's a 10. If it hurts someone else, then it's a 1. And if doctors prescribe based on that information, they end up over-prescribing every time. So even though there was a government agency that recommended these pain scales, and we're still using them, by the way. Hospitals still, every day,
Right.
even for a person who's not in the hospital for a painful problem, like if they had a fever and a cough, they still ask them when they take their vital signs if they have pain and what's the number, and then they just automatically phone the doctor for something to give the patient. If he reports that he has a 7, then they prescribe whatever a 7 would be. The National Institute on Drug Abuse said this is just the wrong way to be doing it, that the amount of pain the patient is in should be assessed from watching his behavior and his movement and how much trouble he seems to be having from his pain, rather than what he says about it.
I agree completely. In my own practice as a clinical professor of rheumatology at UC Davis, I often will tell people our goal is to diminish your pain by about 50% and to improve your level of functioning. Because completely eliminating pain, number one, is often not feasible. And number two, it may not even be desirable because, for example, we know that there's some forms of arthritis that can occur when pain is completely absent. In other words, pain tells an individual to go easier on a joint, to maybe ride a bicycle instead of jogging on concrete. And completely eliminating it is not only not possible, it's probably not a good idea. We don't want people to suffer, but we really should not make it our goal to render everyone pain-free. That's just not realistic. Do you agree with that?
Yeah, it's especially not realistic when you're using a drug which loses its potency the longer you use it. So the problem with, if you can completely control a person's pain by using a monoclonal antibody against their inflammatory condition, that would be a good thing. But if you're using an opiate to control, you're controlling the symptom, but the disease is uncontrolled. And so when you're using a medicine which they're going to need more of the next month to get the same amount of pain relief they have this month. I don't think people properly appreciate that guys on long-term opiate management for chronic pain are generally taking what would amount to a fatal overdose if you or I were to take the medication. I've not been on any opiates for anything. In methadone detox, the person comes in and we give them doses of methadone that would kill a non-addicted individual. So there's, they have to build up a tolerance over a long period of time in order to become that resistant to the effect of the drug. But the pharmacologic benefit has the same phenomenon. You need to take more and more of it to achieve the same amount of pain control.
And by the way, we have, in fact, monoclonal antibodies that will eliminate the inflammation or diminish it greatly in rheumatoid arthritis. They're called biologic agents, and they've revolutionized the treatment of rheumatoid arthritis, Crohn's disease, the arthritis associated with psoriasis, but they don't eliminate the damage that's already been done to a joint. And in a similar way, let's talk about back pain. Probably 90% of all people will have at least one episode of acute back pain in their life. And, it usually resolves about 80% of the time in 2 weeks, 90% of the time in 1 month, 93% of the time by 6 months. But that 7% of people who have chronic pain after 6 months consume over half of the healthcare dollars spent on back pain. And often they end up being placed on opioid analgesics. And as you point out, they end up on high dosages and they suffer a lot of side effects. And maybe you could talk a little bit about how opioids work. They work in the central nervous system mainly, right?
Right, and there's a receptor there, the enkephalin and endorphin receptors in your brain bind to these things and transmit a signal that diminishes the electrical conduction in pathways that are involved in pain transmission. The problem is that these receptors are used, they also disappear off the surface of the cell so that there's fewer receptors, which means you need a higher dose of opiates the second time around to get the same amount of stimulation and the same amount of benefit. And that's called habituation. And it's a part of the addiction process, but it's like there are two components to addiction. First of all, there's the physical dependence on the drug, which can happen to anyone, and that's fairly easy to treat with graded withdrawal. In other words, you start by fixing the dose of drug at a constant level and then take away a small amount over a long period of time. People can be dehabituated relatively easily. Methadone maintenance is a good tool for that, but there are lots of other ones. The second part of addiction is a psychological dependence on the drug. And there are many kinds of addictive substances like cigarettes and so on that are, the psychological dependence lasts for years and years. Even after you've been completely detoxified for a long time, there's still an urge to use, or a feeling that alcoholism is the best example because everyone's familiar with that. But somebody who's been 4 years without a drink will have a traumatic event in their life, and the first drink they have leads to the next and the next, and they relapse.
In addition, Dr. Hawley, I think it's worth pointing out that there are different types of opioids. When we say opioids, we really mean the class of medications that are also called narcotics, the ones you described, but there are long-acting and short-acting ones. That makes a difference, right?
It makes a huge difference in the way you use them legitimately. Long-acting opioids are mainly for patients who have like a constant level of pain throughout the day. And they're used to treat things like cancer, metastatic cancer with bone metastasis and like that, where a person like really needs the things pretty much around the clock. Short-term opioids are normally things like codeine and Vicodin. They generally tend to be a little less potent in the doses given, and they wear off in 4 to 6 hours. If you have a migraine headache or your elbow hurt because you twisted it at something, short-term opioids unfortunately have the disadvantage of they have a sort of a surge. When you take a dose, you start out with nothing in your bloodstream and it surges up and then it surges back down. And what happens as it's headed back down, the pain receptors in your brain are normally at equilibrium with the endorphins and enkephalins that you normally produce. The production of those is suppressed because they're not needed because you have the Vicodin in your bloodstream. As the Vicodin disappears, the enkephalins, they need to be stimulated in order to come back up. So you end up with more pain as the drug wears off than you had in the first place.
So the dilemma we have is that we have about 100 million people in the U.S. who have chronic pain. Until recently as 2016, we had almost 300 million prescriptions for narcotics being issued in the United States annually. In fact, it's been estimated that 80% of the prescriptions for narcotics in the world are issued in the United States. So we have this problem. And the short-acting narcotics, or opioids, seem to create this cycle of stimulating the receptors and then having some withdrawal. So we want to help people who have chronic pain as physicians. Certainly as a rheumatologist, I see it all the time. And we do have other drugs and other methods of treating pain in our armamentarium. So as we discuss opioid addiction as the story of the year, I'd like to sort of take a positive approach and point out some of the things that we could do that don't involve opioids to treat chronic pain. And I'm sure you have some thoughts on this.
Right. when I was working in methadone, in the methadone clinic in Bayview Hunters Point in San Francisco, at that time about 1/3 of the patients in the program were there because they had become dependent through taking prescribed medications, and they just didn't quit. And when the doctor felt they shouldn't take it anymore, they start buying it on the street. And these are people who had never injected heroin. Now I gather it's more like 2/3 of the patients in methadone start out that way, and only 1/3 start out with injection drug use. But the exciting advance in the field is that they've developed drugs which partly stimulate the opiate receptor and partly block it to prevent other drugs from affecting it. So there's a drug that completely blocks it called Narcan. If you have a patient who comes into the jail or in the emergency room and loses consciousness and you diagnose an overdose of heroin or an overdose of OxyContin, you can administer Narcan and they wake right up almost instantly. It's just a perfect antidote. But of course, as soon as they wake up, they begin experiencing withdrawal symptoms, sometimes really profound withdrawal symptoms. But it's better than what would happen if you didn't give anything.
Right, and in fact, if I may interrupt, Narcan is being administered now by first responders in different settings. I believe there's a nasal preparation.
There's now a thing where spouses or people in families who have opiate-dependent individuals that are given Narcan to use in the home. So they'll have it just like epinephrine injections for people with bee sting allergies. Home-administered Narcan is coming into a sort of a vogue right now as a way of, in some of those cities in Pennsylvania where 50% of the people are dependent on opiates, the number of accidental deaths in the community is, by the time the ambulance arrives, it's too late. So this is an intervention.
If I may, it's also important to point out that if a bystander administers Narcan and the person wakes up, the person still needs to be seen in the emergency department because that can wear off. And if you have a long-acting opioid such as fentanyl, they could lapse back into coma.
Absolutely. Even a short-acting one like heroin, the Narcan wears off in 10 minutes or 15 minutes. It's also totally harmless if it's administered to a person who's not on opiates. If they've become unconscious for some other reason. And so it's ideal for community use in that sense because you can't get into trouble with it.
Right.
There's also another category of medications in which the drug itself partially blocks its own receptor. In particular, buprenorphine has become something which is being recommended a lot by government agencies. They now allow, while it requires a complicated licensing process to dispense methadone, you have to have guards and nurses and pharmacists on premise. You have to have a group treatment program going on. It's something outside of what a physician can do. You don't have to have any of those things to prescribe buprenorphine. Buprenorphine doesn't cause overdoses because if you take too much of it, it blocks all the opiate receptors completely. So it's only effective in immediate range doses.
Right.
And so that it has very little street value. If a person who's addicted to opiates takes buprenorphine, it causes withdrawal.
It's important to point out, too, that you really need a strong therapeutic alliance between the doctor and the patient or the client, whatever you want to say, to solve this issue, because an individual really has to want to deal with this as an addiction process, and many people are dealing with psychosocial, economic, social problems that may put them in a state of denial. So you really have to get past that. As you pointed out, sometimes the way people get past that is they're incarcerated. But we want to work towards getting people to really overcome this as a health challenge, which will be a chronic challenge. And you pointed out some of the medications that are involved. Would you like to comment as our time begins to run short on some of the broader cultural or social implications of this opioid crisis and how we as a people, as a nation, can do better in addressing it?
The damage, people always talk about the sudden surge in overdose deaths as though this wasn't a problem before we had all the overdose deaths. The overdose deaths are kind of an artifact of the kinds of drugs that people are using, especially the introduction of China White. which is a drug called fentanyl that's manufactured in China. It's extremely potent. It's like 5 times as potent as morphine or heroin. And you can use a very small amount of it. It's normally given in skin patches for people with chronic pain. But it's very easy to accidentally overdose on fentanyl, and the people in the drug business will add small amounts of fentanyl, which is very inexpensive, to the heroin they're already selling to make it have a stronger effect. But the person who's buying it doesn't know that, and he'll take too much.
As our time winds down, maybe you could talk a little bit about the relationship between prescription drug use and subsequent use of street drugs, and how we could take a more broader, holistic approach to solving this problem.
Yeah, there's no doubt that a lot of the people who are involved in the current problem or the epidemic of opioid abuse started out innocently enough with some sort of ongoing pain. They weren't using recreational drugs to begin with. But regardless of which pathway you go, whether you started with introductory gateway drugs like marijuana and ended up using heroin, or whether you were taking prescribed medications and needed opiates for pain control, what happens is, because you need higher and higher doses as time goes along, the doctor at some point becomes aware that he's no longer treating whatever the initial painful condition was. So if he had an orthopedic problem, you're coming into his office just to get opiate refills. You're now past the original problem with whatever was orthopedically, and the doctor then says, well, I'm not an addiction specialist. You really need to see someone about chronic pain or someone about addiction. And that doctor discharges the opiate-dependent patient from his practice. It's very difficult, if not impossible, for those guys to get opiates prescribed by another community physician, because it's frankly illegal to do that. So he becomes angry, and eventually he has to go into the community and obtain drugs unlawfully. Then he ends up in the system just as though he were a heroin addict, and the system doesn't make much of a distinction. The methadone clinic I worked in was seeing roughly half patients who had become addicted to medications from chronic pain and half who had done it from recreational abuse.
Dr. Holly, we could talk about this for hours, and we still might not be any closer to a solution, but I really feel that the combination of your medical expertise and your clinical experiences really shed some light on this topic. And hopefully, if we talk about the opioid epidemic again in the future, we will have made more progress. So thank you so much for joining us.
It was a pleasure. I love to talk about what I do for a living.
Fantastic. Remember, here at Health Focus, we focus on your health. We've attempted to address the story of the year, the opioid epidemic, as we enter a new year, 2020. And for the new year, all of us here at the studio wish all of you the best of health. Thank you so much for joining us.